Welcome. This is Brian Buchanan from the University of Alberta from the Department of Critical Care Medicine. This tutorial will review visual assessment of the RV function in the ICU in critically ill patients. In this case, we're going to focus on global RV size and systolic function. Although it's only one area in comparison to the LV has many more confounders and in some ways is much more abstract. So why are they so different? Well, in fact, the LV is conical, has 4 muscular layers, can withstand high pressures. Again, has relatively thick walls and perfusion only diastole. The RV, in contrast, is more complicated 3D geometry, wrapped around the LV, acting as a low-pressure circuit with 2 muscular layers, and largely longitudinal and circumferential muscle. It has a thin wall and has much less bioenergetic requirements, in fact, about a fifth of the LV. Perfusion is in systole and diastole, and importantly, the stroke volume is fixed. I often hear other professionals refer to right heart strain. The trouble with this term is it lacks specificity. Right heart strain can mean a variety of things, from RV dilatation to RV dysfunction to right ventricular hypertrophy. And really it's non-specific, but really carries some important prognostication in conditions like pulmonary embolism. So broad differential diagnosis as listed here, everything from PH to PE to RV infarction and so on. And RV strain, as it were, can be detected on ECG, echo, and CT with a variety of characteristics. I would encourage you to correlate these different imaging modalities if you have access to them. First of all, the shape of the RV explains some of the challenges in its assessment. The RV is like a pyramid which wraps around the LV. It has no spiral layer of muscle, and the main motion is longitudinal, similar to an accordion. In this case, the tricuspid valve moves towards the apex of the heart in its main motion. In most TTE views, the RV looks either crescentic or triangular. This schematic shows the various configurations of the right ventricle and its corresponding wall segments. I don't think you need to know this in detail, just understand that the shape of the RV requires multiple different views for its assessment. The personal lung axis view is one of the first places you may see a suggestion of a dilated RV. The anterior segment here, however, is actually the RV outflow tract. Generally, the rule of thirds is helpful in eyeballing this. Interestingly, this is oftentimes a very sensitive part in tamponade. However, I would encourage you to more so focus on an apical 4 or subcostal 4 chamber. On the personal short axis, we see the distinct croissant and bagel formation of the RV. This comparison is courtesy of our own Dr. Jean Deschamps. You'll notice that the LV wall, or septum specifically, is convex towards the RV. The inner cavity is circular in diastole and systole. The septal configuration can tell us a bit about the balance of pressure. Any increase in RV pressure over LV pressure, and we'll see the septum flatten, creating a D-shaped septum. This view is not helpful for assessment of RV function necessarily, and is equally unhelpful in RV size unless the RV is massively dilated. On 2D echo, pressure overload of RV results in the leftward, or towards the LV cavity, shift of septal motion throughout the cardiac cycle. As we can see in the left segment here, we get a persistent flattening of the LV. And you'll notice this D shape is throughout both systole and diastole, a feature specific to RV pressure overload. With predominant RV volume overload, the maximum reversed curvature is seen in mid-diastole, with the influx of volume into the RV. The septal curvature tends to normalize during systole. This is just a basic rule, and certainly can be wrong under certain circumstances. You can see on this image that D shape is persistent throughout diastole and systole. You will need to make sure that you can see the entire LV wall thickness, as this impression is easy to create with a poor short axis view. You can see in volume overload, the septum flattens in diastole, but pops open in systole. This can be easier to see with an ECG tracing and really slowing down an echo loop. I will say not to get too fixated on this, as really other elements of the 2D image can be equally as instructive. Moving on to RV size. RV size is visually compared in a non-foreshortened apical 4-chamber view to the LV. Really we're looking at the LV-RV ratio, measured at end diastole. If we stop the image here in diastole, what we can find is effectively a ratio of the RV, which is 2/3 of the LV. or less than 0.6. If the RV size equals the LV size, then you have moderate dilatation. A severely dilated RV will be actually bigger than the LV. If the RV forms the apex, which is seen more often in chronic RV dysfunction. Again, we can see here that an RV size greater than 2/3 is considered to be significant for RV dilation, and an RV base measurement greater than 41 millimeters is suggestive of RV dilation. On the right, we can see that if the RV forms the apex, and even if normal measurements, this is considered to be significant for RV enlargement. Measurement of the RV is greatly affected by small rotations of the imaging plane. As you can see in this bottom panel, care must be taken to avoid foreshortening of the image plane. You can see here cut 3 may look the RV look small and collapsed, while cut 1 makes it look similar in size and shape to the LV, although this is all from the same heart. So really what you want is number 1, where you're cutting directly through the apex of a left ventricle. The RV focused view can also be attempted. With the apical 4-chamber view, you slide the probe more laterally along the chest wall. In this case, the transducer plane will cut through the center of the LV cavity with the RV size maximized. This will improve visualization of the RV free wall seen in the midfield. Also important to take home is how to distinguish the RV from the LV. By now you may have realized it can be really easy to get confused over which chamber is which. This is especially true if you're not performing the ultrasound. Some key things to consider. The tricuspid valve insertion is more apical than the mitral valve. Generally speaking, the LV forms the apex. The moderator band is almost universally present in the right ventricle, which helps speed conduction. So this can be one suggestion. However, a confounder is that a false chord may be present in the LV, which again is a band-like echogenic structure, which will occasionally make an appearance. If you look at the internal cardiac crux, this is really where we see the LV connect to the LV outflow tract in the middle of the heart. And this can be found with a slight fanning action of the probe looking superiorly to expose the apical 5-chamber. Despite what you may have heard, the wall thickness is usually unreliable, as the RV can also thicken in response to pressure overload. Finally, you can trace the RA to the IVC, especially in the subcostal 4-chamber view. The subcostal 4-chamber is another view to interrogate the RV. This is the most sensitive view to assess for pericardial fluid as a cause for tamponade. And often we find in our ventilated patients this is a readily acquired view. You can also measure RV free wall thickness. This is best measured in the subcostal view at end diastole. You'll need to consider left-sided cardiac function in any assessment of the right heart as well. Again, to measure the thickness, we pass the M-mode beam towards the RV free wall, revealing this M-mode recording. We'll want to exclude any epicardial fat or myocardial trabeculations. A normal thickness measured in M-mode is less than 0.5 centimeters or 5 millimeters. Even after 48 hours of increased afterload, you will see the RV thicken, as the RV is not normally used to increased afterload as it's a high-volume, low-pressure circuit. This RV-free wall may thicken as much as 1 centimeter or 10 millimeters. It may help determine the acuity or chronicity of RV dysfunction. This also explains why the free wall in normal states doesn't do much, but increases in importance with worsening right-sided pressures. RV systolic function. The RV systolic function is best measured by looking at the vertical translation of the tricuspid annulus as the annulus moves towards the apex. If you place the M-mode to the lateral annulus, you should see at least 1.7 centimeters of vertical movement. This is descent of the annulus towards the apex, and this is called the tricuspid annular plane systolic excursion. The M-mode recording can be seen here in the bottom with these 2 crosshairs, which show the vertical movement. Again, consider that this M-mode recording is time motion display, so really we're just measuring the gross vertical distance between the annulus at one point compared to the annulus at another. You can see here in this example why it's important to have crisp endocardial boundaries. The M-mode recording is placed in the lateral annulus, and we can see this vertical translation of the annulus in real time. Now we'll measure from end diastole to end systole to look for a comparison, which gives us 0.64 centimeters, which is less than 1.7 centimeters, and in fact, severely depressed. We don't generally categorize the RV function in distinct categories. If it's less than 1.77 centimeters, we just say that there is RV systolic dysfunction. And I would argue that really it's the patient's clinical status which may tip your hat as to whether or not it is truly severe. TAPSE is one of the best indicators of change in RV function in response to therapy, such as inotropes or milrinone. There are many caveats to TAPSE. It's really one component of RV function, and there's no information about radial contraction of the RV. It is angle dependent, and you need good alignment, 90 degrees to the tricuspid annulus. And normal TAPSE does not equal normal RV function. You can actually have a normal TAPSE and a grossly abnormal RV stalk dysfunction, as TAPSE is only one parameter. However, given the complexity of the RV, it is really the only instructive bedside parameter that is really quite effective in the setting of critical care. And an abnormal TAPSE probably does mean abnormal RV. However, in patients with pulmonary hypertension, I'd be a little more cautious. So the key is really putting it all together. Do they have a dilated RV? Do they have septal flattening and evidence of ventricular interdependence? Do they have an underfilled LV where the RV fills at the expense of the LV? And do they have a dilated IVC? Really, it's all these basic 2D or brightness mode parameters that are really important to put together that will help paint a clinical picture. This highlights why it's important to have a collection of views to really put the pieces together. Clinical integration is really what matters here, and that's kind of the so what of all this. Finding a right ventricle that is ailing should prompt you to consider a differential of possible causes of RV failure, but should also prompt you to consider what changes you can make at the bedside, such as addressing PEEP, acidosis, or hypoxia, which are all things that can negatively impact RV function. It may require a down adjustment of PEEP, conventional medical therapy for acidosis, or obviously addressing hypoxia, which may increase RV afterload through increasing pulmonary vascular resistance. These are all things which can improve RV function should you have a patient with profound RV dysfunction. Again, check the website for further materials as reference. I'd like to thank you for listening and hope you enjoyed this tutorial.